So please stay online. I think some people are maybe stuck in Hoover from what I can gather. You'll still be able to participate in this part. We are going to set up some breakout rooms, which will be a little bit of fun in a minute. This session's about optimizing first line care, and something that as a group we're very passionate about. In order to do that is we need to optimize patient education to get people on board first line care. So I'm going to pass it over to Ali Gibbs, who's a PhD candidate with us at La Trobe University, and is also an Oaks physiotherapist here in Victoria, so has some amazing specialist knowledge in how to manage complex and difficult osteoarthritis patients. And she's going to talk us through some principles around patient education, and then we're going to have some fun and get you guys in small groups. And you have to do some role play. You're going to have to be a patient, or you're going to have to be a therapist, and providing some education to see if we can steer people towards giving first line treatment an adequate trial. So I'll pass it over to you, Ali.
Thank you. So I'll just get the share screen up. Okay. So the GLAD program, as you're probably aware, after the last few days, includes 12 sessions of exercise, but importantly, it also includes 2 participant education sessions. So when the physios attend the GLAD training, as well as going through what's included in the participant education, as Christian said, they also do the role play. And it's a really important part of trying to equip physios with how to be able to address patient concerns, questions, and misconceptions. So again, as we've already heard today, the language used around osteoarthritis and patient beliefs with bone on bone, the joints worn out, can result in that perception that exercise is harmful and surgery is the only option. How can anything else possibly help if my joints were worn out? And there are several papers that have identified that this is a pretty common belief, but not only in patients, also in clinicians as well. And challenging this perception is important, both for gaining patients' buy-in to non-operative management strategies, but also, as we heard earlier today, it can improve people's confidence in their knee. So in an effort to try and change the messaging regarding knee osteoarthritis, an editorial in the BJSM in 2019 did a call to action for changing the narrative. So the first step is to try and change the message away from the traditional biomedical model of osteoarthritis being described, as we said, bone on bone, wear and tear, and then the subsequent impact that has on patient beliefs regarding surgery and the need to fix the damage. As we said, it also makes people more likely to be concerned that exercise is going to make things worse, it's going to wear the knee out, and that makes sense to patients. Why would you exercise a joint that's wearing out? So changing the message to focus less on structural changes and more on pain being something that's modifiable with things like exercise, physical activity, and other non-operative management strategies can help gain that buy-in. So talking in terms of joint pain being related to sensitized structures, as well as being influenced by the other factors, may help change then the treatment focus. So shifting away from the need to fix the knee and focusing instead more on what people can do, what they can modify. That can then lead to putting the patient in charge. So we've talked a bit about patient-centered care today already as well. So it's about helping people have a positive mindset towards long-term self-management, coaching them to be confident to engage in exercise, discussing the lifestyle factors, education about osteoarthritis and treatment options, education support tools. So there's several online platforms that have been set up that you can refer patients to. And La Trobe University has a PhD candidate at the moment who's working on an online patient resource that's able to then be tailored to the individual patient, to what's of particular concern for them. So I highly recommend looking at this paper. It also includes some examples of how the narrative can be discussed or changed, as well as the infographic that you just saw previously. So again, JP just presented very nicely about all the psychosocial factors that can also contribute to pain. So we know there are people who have radiographic OA and no pain or disability. And on the flip side, there are people that have pretty mild changes on imaging but have severe pain and disability. So why is this? So we all know pain is complicated and influenced by many factors. So again, as JP went over, so things like mood is an important factor. People with osteoarthritis are twice as likely to report high or very high psychological distress compared to those without. And this distress can be associated with increased severity of pain. People with high levels of anxiety and fear avoidance beliefs have lower levels of self-reported function. Comorbidities such as obesity and diabetes can also influence pain severity. Sleep disturbance is common with OA and linked with depression, disability and pain. And then there's also muscle weakness, particularly quads weakness, associated with disability. So helping patients and clinicians understand that there are potentially modifiable factors that contribute to people's pain and disability can then help with the buy-in to undergo the management strategies other than surgery. So education tips. Don't start with with an information dump. So try not to feel like you're just lecturing the patient, telling them this is what works and this is what you need to do. As it's been talked about several times today, it's about being patient-centered and individual to the patient, particularly if the patient is still having the belief that it's bone on bone and you just tell them to go and do exercise. That's just not going to work. Trying to reflect the key information is a way of just demonstrating that active listening. Trying to ask and understand the patient's perspective. So questions like, what have you been told about your knee? What do you feel is going to help from here? What are your thoughts on surgery or exercise? Can sometimes try and gently challenge some of the beliefs. So things like, did you know recreational runners are less likely to have osteoarthritis than non-runners? So it's trying to plant the seed that exercise and activity isn't harmful. One advantage with physio consultations is that they tend to be longer than both GP or surgeon consultations. So physios are in a pretty good place to have that time to deliver the education and the behaviour change. But it still can be a really difficult and challenging thing to do. So as Christian said, we've got some role play questions here. And this is, as I said, part of what we do in the GLAD training. So one person is going to be the clinician and one person is going to be the patient who's coming in saying, have you seen my x-rays? It's bone on bone. How can exercise help with that? And then the second question, I've done the exercises, but my knee's still sore. Why? What can I do to reduce the pain? And then if you get time, the third question, I get it that some people can have OA and have no pain, but my knee's sore. Why? And feel free to be a really demanding patient that grills the clinician. So you're having to really make them think how to answer the question.
Great. Thank you, Ali. So see if you can remember at least those two questions as we go here. 4 or 5 people have just dropped away for an early lunch. I think they were scared of having to be the patient or be the therapist, but good to see plenty are still on board here. Those who might be in Hoover, if you are, you can still have a go yourself, maybe have a think about how you might answer some of these questions. I'm going to set up the breakout rooms now, and JP, Ali and I will rotate through the rooms, and then we'll come back at the end for 10 minutes and have a bit of a conversation and discussion about how we tackle some of these challenging questions. So I'm going to set up half a dozen rooms and see if you can have a go at being a patient and see if you can have a go at being a therapist. So I'm just opening up the rooms now and we'll see you on the other side of them. So you'll see it pop up as a request or an invitation. There's a couple of people online that haven't joined. So let anyone who's having trouble not seeing how to join the room, let us know and I can see if I can get you there. But otherwise. Most people in there. All right, I'm going to jump into a room, Ali. Have you been invited to a specific room? Hopefully you should be able to jump around. Okay, I'm going to go over to a room. Okay, welcome back, everyone. I think there was some mixed success there with some people getting put in rooms with nobody else and others not joining, but I think there were some good conversations as well, which was really good. I think everyone found some friends to talk to in the end, so that's great. I might open it up, first of all, just to the people who are not tutoring in this little workshop. Any thoughts or questions on the challenges of answering those questions? Don't be shy. Feel free to turn your cameras on, everyone. It's a much smaller group than a big conference group. There we go. Seeing some nice faces. Is anyone brave enough to talk or ask any questions? Or do I need to ask some questions? All right. I'll ask. Oh, yep. Jonathan, go.
Sorry, I just had to turn my mic back up there. I suppose I didn't answer the question, but I guess one of the things that as I guess a bit more of a stubborn patient is that they're always coming with their already preconceived ideas and beliefs, and that they've already got like an idea of what they want to achieve out of their session, which is that they want to move on to the next phase of treatment. That they've tried exercise, they've tried all of this, and they think that the next pathway is the only next stage is surgery. So I guess the hardest part of navigating that is trying to, I suppose, adopt those strategies that you try and get your patient on side. And it's, as you said, I think previously before as well, is that it can be really difficult in such a short space of time. And I guess you're not really going to expect to change someone's mindset so quickly. They've already come with this goal that they want to achieve on their own. And JP said in our session as well, I guess it's not straight away about trying to give that feedback straight away, and it's slow and it's frustrating sometimes. I suppose it's about getting them to reflect on their own experience so far, and having to obviously come to their own conclusions of what they need to do to change.
Yeah, I think that's a really good point. I think I typically, with a patient like that, try and ask lots of questions to them to understand where their beliefs are coming from. And that gives you an opportunity to fill in any misinformation that they might have and fill in those gaps. And it has to be a slow journey. I might throw that because it's sort of a question to Ali. Do you have any tips for those patients, Ali? You deal with them all the time in your setting where they're sometimes coming thinking they're seeing a surgeon and they're seeing you as a physio. How do you approach that?
Yeah, no, it is really challenging. Part of it depends on, obviously some people are appropriate for surgery, so they have tried good quality physio previously. They do have severe change, and absolutely they're good candidates to then be referred on to the surgeon. If it becomes more challenging when it's someone that you think hasn't sort of optimized the non-operative management first, depends, obviously very specific to the patient, but one thing I sometimes try with people is that there's no going back from surgery. So once you've had it, you've had it. And the outcomes for most people are good, but not for everyone. With exercise, you can try it for a period of time. It's not saying that we won't then look at referring you on to see the surgeon, but you're trying other things first. Another way I sometimes also try and sell it to patients is that you kind of can't lose by doing the exercise first, because it can help with the recovery afterwards by having good muscle strength beforehand, trying to be more physically active beforehand. You've got all the other health benefits with that. So you're not dismissing that surgery is off the table, but you're trying to sort of nudge them towards ways that you can do other things as well. But it's challenging, really challenging.
JP and Joe, anything to add to that? Or does that sound pretty good, your sort of approach?
Yeah, I think Ali's really hit the nail on the head about the complexity. And, you know, Ali is very much in that position where patients come with an expectation, and sometimes that expectation shifts when they realise that they're seeing the physio, not the surgeon. And so that adds to the complexity of the challenge. I think it's one of those things that even the most experienced physios find really challenging to deal with. It's breaking down some of those preconceived ideas. So I think Ali summarised it really nicely.
Yeah. JP?
Yeah, and I think, I second what's been said before, but I also think that we can try to educate the patient. We can try to give patients new beliefs and explanations, but they often come in with a lot of data. They have a lot of experience, and they tried a lot of things. So the experience will speak for itself. And often the beliefs will be challenged through what they learned through their own experience. And if the patient is willing, I think what we can do is invite them on a journey and say, look, I can see you've been through a lot. But also, based on the reflections that you and I have made in your story and the things that you have tried, it looks like you have gaps in the story, or you haven't done enough, or the things you've done are really provocative from the start. You never had a chance to actually start doing well. So how about we work on those gaps, try to bridge those gaps, and try this for a period of time, and we see how we're going to come out on the other end. And look, at the end of the day, you're trialing the best that you can do, and surgery is an option at the end. It's not a failure; it's an option. And I think inviting the patient on that journey is a bit more inclusive than just telling them, look, exercise is good, surgery is not good, and your beliefs are wrong. That's not going to work. And just going on your question, Jonathan, it's very rare that you change someone's beliefs straight away, especially by talking to them. But by the end of the first session, if you gave them enough experience and they feel safe in their own body, and they can see that they can use their body in a different way, then they may reconceptualize what pain means, and that may challenge their beliefs on that by themselves.
Really good advice. Anton?
One thing that I've found helpful in my OAKS clinics is assessing people's quad strength. I use a simple open chain paradigm starting in supine with a slightly flexed knee, and put a weight on their ankle and see how easy it is to extend their knee. And demonstrating to people that their knee is their quads is really weak, and if they've got unilateral pain, unilateral OA, you can compare it to the contralateral leg, and they can see that their quads is really, really weak, and I say to them, well, look, you need to improve that. That's why it's giving way. That's why it's not protecting, etc. And so that it's a clear demonstration that they've got something to work on.
Yeah.
And I've found that there's quite often some good buy-in with that.
So it's providing some information to them and new knowledge that justifies why they should give an exercise a try. I think it's a really good point.
Yes.
And I think you can use that for lots of different things. So getting their story that JP was talking about, measuring their strength, whether that be knee or hip or whatever it might be, and then showing them that, hey, the way we address this is exercise. I think that's really important. We've only got a few seconds left, or a minute or so left. Does anyone have any final questions for the group here that they want to ask? No? Because I think we're due to wrap up at 12. So rather than open up a can of worms of a whole other question I would have asked, I might leave it there. But just to say a really big thank you for everyone for sticking around for this workshop. I always find this fun when we teach GLAD, and hopefully the guys who did some role playing found it enjoyable and fun. And I encourage you to practice it with your colleagues, because it's a really good way you can hone your skills about what you're going to say when that difficult patient asks you those questions, because they continue to come. But otherwise, I'll pass it over to Sid, and we'll see you guys all this afternoon. Thank you.
Thanks to all of our facilitators and all of our participants for joining us in that session. So we've come to our lunch break now. Just a reminder to everyone that we'll be joining back at 12:30, and we'll be joining back to the webinar again. So for those of us on Hoover, please use the agenda to join back in for our session at 12:30. And for those of us on Zoom, we'll be putting up the meeting ID for you to join as well. Just bear with us as we transition over now.
And massive thanks, JP, Ali, and Joe. I forgot to say that. Thanks.